Welcome to this presentation on posterior communicating artery aneurysm clipping, intraoperative complications, risks, and surgical management strategies. In this session, we'll review the major intraoperative complications encountered during posterior communicating artery aneurysm surgery and the techniques used to prevent and manage them safely. We'll discuss the causes of intraoperative rupture, the factors that increase surgical risk, and the importance of preserving critical vessels and nearby neural structures during clip application. These complications can change outcomes quickly. We'll also examine practical management strategies, including temporary clipping, vascular control, and the use of intraoperative adjuncts such as microdoppler and indocyanine green angiography to improve surgical safety and clip accuracy. Join the study neuro community for more high-yield neuroscience education and clinical pearls across YouTube, Facebook, TikTok, Instagram, X. Posterior communicating artery aneurysm clipping is a high-risk microsurgical procedure because the aneurysm lies close to critical structures such as the internal carotid artery, the anterior choroidal artery, and the oculomotor nerve. Even small surgical errors in this region may cause vascular injury or neurological deficits. There is little room for error. Intraoperative complications can significantly affect patient outcomes, especially when aneurysm rupture, perforator injury, or difficult clip placement occurs before full control of the aneurysm is achieved. Brain retraction injury and cranial nerve dysfunction may also develop during exposure and dissection. Rapid recognition and response are critical. Successful surgery depends on precise microsurgical technique, careful anatomical dissection, and effective management of complications as they occur in the operating room.
Intraoperative aneurysm rupture is one of the most dangerous events in aneurysm surgery. It must be anticipated early. It refers to sudden tearing of the aneurysm wall during the operation, which can occur at different stages and immediately disrupts control of the surgical field. It is a true surgical emergency. It may happen before proximal control is secured, during dissection around the aneurysm, or even during clip application when the vessel is being closed. Timing is unpredictable. Bleeding is often sudden and heavy, quickly obscuring the operative field and making visualization difficult, which can increase the risk of further injury and worsen outcomes. Control becomes very challenging. Higher risk periods include early exposure, manipulation of the aneurysm dome, and final clip placement when the wall is most exposed and fragile. These are critical steps. Risk also increases with raised blood pressure, a weak aneurysm wall, and dense adhesions that make dissection more difficult and less controlled. Small factors can matter a lot.
Preventing intraoperative rupture begins with control before dissection starts. Preparation is key. Blood pressure is kept low and stable to reduce stress on the aneurysm wall, while early control of the internal carotid artery helps secure inflow before the aneurysm is handled directly. This reduces sudden failure risk. CSF is released in a controlled way to relax the brain, and sharp dissection is used to avoid unnecessary pulling on fragile tissue, especially around the aneurysm dome where rupture is most likely. The dome is never used for traction. Care is constant. If rupture occurs, the first step is to control bleeding and regain visibility. Direct pressure near the neck and strong suction help clear the field so key structures can be re-identified quickly, and a temporary clip is often applied to reduce blood flow. Time is critical here. When rupture happens before proximal control, urgent measures are taken. Fast action matters. Carotid compression and lowering blood pressure help reduce bleeding, while anesthesia, hyperventilation, and agents like mannitol or rapid CSF drainage support brain protection during the emergency. Everything is done in coordination.
Early proximal control of the internal carotid artery remains the most important preventative step because it reduces aneurysm tension and allows safer dissection, though it must be limited to avoid ischemic injury. Control must be balanced.
Vascular complications in posterior communicating artery aneurysm surgery refer to injury involving small but very important blood vessels that run close to the aneurysm. These vessels are not large arteries, yet they supply critical deep brain structures. They are easy to miss. Very easy. Among the most important are small perforating branches of the posterior communicating artery and the anterior choroidal artery. These vessels are delicate and often hidden during dissection, running close to the aneurysm neck or dome. During clipping, they may be stretched, compressed, or unintentionally caught in the clip, especially when the anatomy is tight or distorted by the aneurysm. When these vessels are injured, the result is reduced blood flow to deep brain regions. This can lead to ischemic stroke, where brain tissue does not receive enough oxygen to survive. In more severe cases, the injury becomes permanent and results in significant neurological deficits, affecting movement, vision, or cognition, depending on the territory involved. Prevention begins with careful identification of these small vessels before any clip is applied. The surgeon must actively look for them, not assume they are safely away from the operative field. They can be present in unexpected positions, next to the aneurysm neck or partially hidden behind it. Preservation of these vessels is a key principle during clipping. Gentle dissection is used to separate them from the aneurysm wall, and clip placement is adjusted to avoid any direct compression. The goal is simple but demanding. Keep blood flow intact while fully securing the aneurysm. That balance defines safety in this part of the operation.
Cranial nerve injury in posterior communicating artery aneurysm clipping most commonly involves the oculomotor nerve. This nerve controls most movements of the eye and also the eyelid. It sits very close to the aneurysm in this region, very close. Because of this proximity, it is at risk during dissection and clip application. Injury can occur in a few ways. The nerve may be directly manipulated during surgical exposure, especially when tissue planes are tight and the aneurysm is adherent. It can also be affected when the aneurysm dome is stuck to surrounding structures, making separation difficult and increasing the chance of traction injury next to the nerve. When the oculomotor nerve is injured, the clinical features are usually clear. The eyelid may droop due to loss of levator function. Eye movements become uncoordinated, leading to double vision. The eye may also deviate outward and downward because opposing muscles are no longer balanced. These signs often appear soon after surgery. Prevention depends mainly on technique and restraint. Gentle dissection is important when working around the aneurysm and adjacent nerve structures, especially when adhesions are present. Traction should be avoided as much as possible because pulling on the aneurysm dome can transmit force directly to the nerve and worsen injury. Careful handling reduces risk, even in tight anatomy.
Brain injury from retraction refers to damage that occurs when brain tissue is held aside during surgery to create space for access. In posterior communicating artery aneurysm clipping, this usually involves the frontal and temporal lobes, which are gently moved away to allow visualization of deep structures. This is necessary, but it carries risk, real risk. The injury happens when retraction is excessive or maintained for too long. The brain is not meant to be held under constant pressure, and prolonged force can disrupt normal tissue function. Over time, this stress can lead to swelling or direct tissue damage, especially in sensitive cortical areas next to the surgical corridor. When this occurs, two major problems may develop. The first is edema, which is swelling of brain tissue due to fluid accumulation. The second is contusion, which is a form of bruising where small blood vessels are damaged within the brain tissue itself. Both can worsen neurological recovery and increase pressure inside the skull. Prevention is centered on reducing mechanical stress on the brain. Retraction should be kept minimal and only as much as needed for safe visualization. Cerebrospinal fluid drainage is used to relax the brain naturally, which reduces the need for forceful retraction. This step is important. Very important. Additional supportive measures may also help protect the brain during surgery. Mannitol is often used to reduce intracranial pressure by drawing fluid out of brain tissue, and controlled hyperventilation can temporarily lower brain volume by reducing carbon dioxide levels. These strategies are used carefully, not excessively, to maintain a safe operative environment.
Clip-related complications refer to problems that arise after or during placement of the clip on a posterior communicating artery aneurysm. The clip is meant to completely close the aneurysm while keeping normal blood flow through nearby arteries. When this balance is not achieved, complications can develop. This step is very critical. Incomplete clipping happens when the aneurysm is not fully closed off. Blood can still enter a small remaining opening within the aneurysm sac, leaving a residual cavity behind. That residual aneurysm may stay stable, or it may later grow, and in some cases, it can increase the risk of future rupture if not identified early. Another issue is vessel compromise, which means nearby arteries are unintentionally narrowed or affected by the clip. This may involve the internal carotid artery or the posterior communicating artery, both of which are essential for brain blood supply. When their flow is reduced, the effect can be significant and immediate. When blood flow is reduced, the brain tissue may suffer from ischemia, which means it is not getting enough oxygen. If the reduction is severe or continues, it may progress to infarction, where brain tissue becomes permanently damaged. These outcomes can lead to lasting neurological deficits, depending on the affected area. Prevention begins with selecting the correct clip for the aneurysm shape and neck anatomy. A poorly matched clip increases the chance of incomplete closure or vessel narrowing. This choice is not small. It matters a lot. Intraoperative verification is also essential before finishing the procedure. The surgeon must confirm that the aneurysm is fully excluded from circulation and that surrounding vessels are still open and flowing well. Careful checking reduces the chance of missed problems and improves surgical safety overall. Intraoperative adjuncts refer to additional tools used during posterior communicating artery aneurysm clipping to improve safety and confirm that the aneurysm has been treated properly. These tools do not replace surgical skill. They support it. Simple idea, but very important. Indocyanine green fluorescence is a dye-based imaging method used during surgery to show blood flow in real time. After injection, it allows the surgeon to see whether the aneurysm has been fully excluded and whether nearby arteries are still open. This helps confirm the result before the operation is completed, especially in tight or complex anatomy where visual judgment alone may not be enough. Intraoperative angiography is another imaging technique used in the operating room to evaluate blood vessels while the surgery is still ongoing. It provides a more detailed view of circulation and helps detect problems such as incomplete clipping or unintended vessel narrowing. This is especially useful when the anatomy is distorted and direct visualization is limited. Papaverine is a medication used during surgery to treat or reduce blood vessel spasm. It is applied locally when vessels become narrowed or irritated, helping to restore smoother blood flow. This is important in delicate brain surgery, where even small reductions in vessel diameter can affect oxygen delivery to brain tissue. Together, these adjuncts act as safety checks during aneurysm clipping. They help the surgeon confirm that the aneurysm is fully secured and that normal circulation is preserved. They do not change the goal of surgery. They make that goal more reliable, especially in high-risk and complex cases.
In summary, intraoperative complications often determine the final outcome in aneurysm surgery. They can quickly turn a stable procedure into a high-risk situation when not anticipated or controlled with disciplined technique at each stage of the operation. Small events can change everything. Good outcomes depend on several core principles working together, where early vascular control, gentle microsurgical handling, and adequate exposure all reduce tension on the aneurysm and improve safety during dissection and clipping. It is never a single factor alone. Real-time judgment is as important as technical skill because the surgeon must continuously adjust decisions based on bleeding, anatomy, and tissue response.
and success relies on precision, preparation, and constant attention throughout the procedure. Thinking and action stay linked. This is Study Neuro. We provide focused neuroscience education and practical clinical insights across major social platforms. Follow, like, comment, and subscribe for more updates and learning content.